I think if you have space, got it.
Right?
Okay, thanks.
So just a disclaimer about what we're going to be talking about in terms of standards of treatment, because it's very important before every presentation I give. That is, all the treatments that we talk about, they're carried up to the standards and guidelines set by the ESE. All treatments carried out are under rubber dam and operating microscope, because again, that is the guidelines of ESC. IADT, that's the trauma guidelines, where if we do talk about trauma, we're going to be following the 2020 guidelines by the IADT. And all the treatments that we carry out in this presentation, they are all peer-reviewed based evidence from peer-reviewed journals. Okay, so everything that we do at King's is based on evidence, and we keep improvising based on that. So everything we talk about today will be with regards to that too. All right, so the aims of treatment of our presentation today is diagnosis, because CBCTs is a diagnostic tool. So diagnosis is the key, because without that, we have absolutely nothing. Okay, we're mechanical workers. Clinical cases, of course, to consolidate or resolve about why to use CBCTs. Outcomes of these cases, where and when applicable. Misconceptions with regards to CBCTs as well. We'll be talking about that in general terms for radiology as well as CBCTs as well. Okay, and as I said, everything we talk about today is all about evidence. So there's going to be a paper that I will cite probably with every case that I show, if not all, almost every case I would say, to back what we're going to be talking about in this presentation. All right. So sorry. Right, so I'm going to get straight right into it. So why and when CBCT? So CBCT, of course, is 3D view of a 3D object. The ESC tells us that we should be using it as inconclusive. 2D radiology has a lot of limitations.
Dr. Vandana, can you mute yourself, please?
Sorry, I just went back. Right, should I continue, Burzine? Burzine, should I continue?
Yes, continue. I think she's muted. Yeah.
All right, perfect. So why and when CBCT? So, as I just said, the CBCT is a holistic view of a tooth, of your anatomical landmarks. It's more precise. Through this whole presentation, we'll go through about how and why. There's enough evidence to say so. 2D radiology has a lot of limitations, and yes, we do know that we don't have access to CBCTs on a day-to-day basis, but when to pick CBCTs and why are they most superior, okay? So when we look at the ESC position statements, all of them talk about inconclusive diagnosis, which is fair and fine, because we do not get a conclusive diagnosis in a lot of the cases when we deal with 2D radiology, all right? So why and when CBCT? When you have an inconclusive diagnosis, so if you have clinical signs and symptoms that do not correlate with the presence or absence of a periapical lesion, for example, okay, we go through that you may have signs of apical periodontitis, for example, but you can't see it on a radiograph, and you start to ponder as to, is it that or is it this? But there's a lot of clinical testing that goes along with it to consolidate a result for using a CBCT to actually refer for one, all right? So if you do not have your clinical testing right, if you do not have your interpretation of 2D radiology correctly, the use of CBCT is not redundant, but you will not pick up what you want to know, okay? Then we have complex anatomy, because you have superimposition due to the roots and due to the angulation of x-rays, and of course, it being a limitation as well, all right? Retreatment. So I personally take a CBCT for all my retreatment cases, because I like understanding why it has failed, okay? Regardless of a lesion, no lesion, you can have missed canals, you can have you can have suboptimal root fillings, but it doesn't matter, okay? You know why it potentially would have failed, but a CBCT will make you understand more so why it has actually failed, okay? Because when you have a failure in endo, you can have a multifactorial failure, okay? So retreatment for me, every case that I do, I would be taking a CBCT, because I do not believe in walking in on surprises, okay? So that's one. Then we have perforations. Again, you may not see a perforation on a radiograph, but you have to have a clinical testing in place to suspect that there may be a perforation and therefore refer a CBCT. You may have a CBCT in-house, that makes your life much easier, but most of the people don't. So if your diagnosis or your diagnostic tests are not in place, you might not know what's going on to actually refer a patient. And perforation is one of the tricky challenges that you may face as well. Vertical root fractures. So how we detect vertical root fractures on a CBCT is based on the pattern of periradicular bone loss. If anybody tells you that you can actually see a vertical root fracture on a CBCT, they don't know what they're talking about. Yes, you can see it in certain cases, but I can promise you this, that in most of the cases, you will not be able to see it, okay? So how you diagnose a vertical root fracture is dependent again on your clinical testing, your findings based on that, and the pattern of bone loss. If you can see a fracture on a CBCT, you're going to be able to see it under magnification. We have enough of papers from the JOE and the IAJ to support this statement as well. We're going to be talking about vertical root fracture as well. Okay, so we have a section of that where we're going to be talking about how to diagnose it and the limitations of CBCTs associated with it too. Then dental trauma as well. We will talk about that very briefly. So since we just have an hour, I've tried to compile a case of each kind to kind of show you as to why CBCTs. Okay, so we won't get into too much depth. We can't teach you how to use a CBCT, but we can teach you as to why you should refer a CBCT. Resorption, external, internal. We'll talk about the new classification, 3D versus the 2D from Hidase from the early 1980s. Differentiating odontogenic and non-odontogenic origin of symptoms. Again, when you have inconclusive diagnosis, something says that it may be this, but you're not too sure. Say if it's a vital tooth, you have a lesion there. How do you confirm that? All right. So a CBCT will tell you the margins of a lesion, if it's associated with the tooth or not. Pre-surgical treatment planning. So assessing anatomical landmarks when you're doing surgery, that will help as well. Okay. So I've not added any cases on this because it's a very vast topic. But apart from this, everything else, there is a case to talk about with regards to why and when CBCT. So as I mentioned, why walk into surprises? Enhanced diagnosis builds everything. I always say this, it may be offensive at times, but without diagnosis, we glorify plumbers, okay? You can teach a monkey to do a root canal treatment, but what differentiates a medical professional from a monkey is understanding why you're doing it. So you have to compile all your different diagnosis, all your testing into place to come up to why it has failed, factors affecting success, outcome prognosis, everything to tell you if this treatment will be successful or not. Okay. So even for primary cases, not that I do too many, I work in referral practice, so I do mainly retreatments. But even if I'm doing a primary, I would still take a CBCT just so that I can understand anatomy, understand where my axis may be, measure my working lengths, even though we have apex locators, but it saves me time and makes it more predictable. Okay. So sorry. Can I continue? There's someone's
Dr.
mic
Rachna,
on.
Dr. Rachna, can you mute yourself, please? Shaurya, as you are the host, just if you can mute all participants, just select that option.
Let me just see how I can do that.
Go to participants.
Okay.
And you will have
mute all, is it?
Yeah, mute all.
But my cursor is not showing, so I cannot really drag onto it.
Yeah, you'll have to stop sharing and then do it. Sorry. I got it. No, only my presentation is working. So it's okay, carry on. I think carry on. That's fine.
I have to exit this first. Okay. I'll just do that now. Then even you get muted, so I don't want to do that. So just in case we need to relay messages. Right. So limitations of periapical radiographs, as I already said, and you're going to see over this presentation as well, that it is, yes, they are very important. You have to take your periapical radiographs when you're doing your case assessment, when you want to do your treatments. They have their place and they're irreplaceable. All right. But they have their limitations. So as we know, it's a 2D view or 3D object. No matter what technique you use, bisecting angle, parallel technique, doesn't matter. It's going to be a 2D view of a 3D object. Okay, your 3D, this only shows you a 2D plane of it. Compression of 3D anatomy, incomplete information. So you have anatomical landmarks, for example. You're going to get compression of that, including your teeth as well. You know, either compression, elongation, depending on how you take your radiograph, how you angle a collimator, that's a limitation. Anatomical noise, you have a maxillary sinus, your thickness of cortical bone, superimposition of roots, mental foramen, and your zygomatic buttress obscuring areas of interest. So what that would mean is that if you want to take an X-ray, for example, of an upper six, and you have your maxillary sinus, maybe pneumatized or not, but you can have obscuration of that area of interest, which is the tip of your root, with the superimposition by the maxillary sinus. Okay, that's just an example. So you may not be able to see a lesion because of that thickness of cortical bone as well. So when we take CBCTs, you can actually see if there's a lesion or not when you compare to 2D, because there's a study, I think, from SHAURYA, I think from 1976, if I'm not mistaken, where they talk about perforation of a certain bone that will show you a lesion on 2D radiograph or not. Okay, so you need a certain thickness of inflammation in the bone to be picked up from in a radiograph, but on a CBCT you're going to see it regardless. Okay. Geometric distortion. So if you find it difficult to get accurate images, you low arch space, because patients can have different arch lengths. A gag reflex, we're going to talk about that, where there was an improvisation of a case that I did when a patient was kind of rejecting taking a radiograph. Small mouths, restricted mouth opening. These all can be difficult, and this is where CBCT comes in your use. Okay. So going back to a part of my introduction, everything we talk about is about, it comes from the ESC guidelines, because they have a position statement about why and when CBCTs. And this is from King's College London, because Prof. Patel is the one who introduced CBCTs to in endodontics, right? So that's me and him. We're at the pub on a casual Wednesday evening. He was one of my supervisors for about 4 years. And it was an absolute pleasure to learn from him. So we do a lot of research at King's with CBCTs in different dynamics about tooth volume, outcomes, trauma, everything. We churn a lot of research from King's College London. So yeah, he is the king of CBCTs. Prof. Francesco Manocci, that is my professor. For me, he's the godfather for endo. He is the one who runs the entire show at King's, and yeah, he's an absolute genius. So to be under him was, again, an absolute pleasure. So I have to give credit where it's due. Right. So going into what is a very not controversial rather, but a misconception or a big topic of discussion is about, what about radiation exposure when we talk about CBCTs? Because you have patients who might ask you, like, for example, in India, we don't get asked many questions about a diagnostic tool when it comes to radiation or in any sense, because they have a lot of blind trust. But in the UK, for example, or in America or in Europe, we get a lot of questions that, oh, we have to go for a CT scan of some sort. What about radiation? That is going to affect us? Is it mandatory? But in all honesty, it really does not make that much of a difference. It's quite negligible, because if you look at this parameter that we have here on the chart, okay, so if you take a periapical radiograph, you're going to be exposing the patient to about 5 microsievert. If you take a panoramic X-ray, that's a DPT or an OPG, as many may call it, that's 6 microsievert. If you have a bag of Brazilian nuts, which is radioactive, it's 10 microsievert. If you take a lovely summer trip from Paris to Tokyo or vice versa, return flight, That's a 150 microsievert. Then you have a conventional CT scan. So if you're going for a CT scan, you're going to be exposed to about 1,320 microsievert. All right. Sorry, I just went back on that. Right. If you live in India, at the end of the year, you can expect to be exposed to about 2,400 microsievert. If you live in the United Kingdom, your background radiation will be at 2,700. In an industry, nuclear industry, your annual exposure is about 20,000 microsievert. Okay. You need to be exposed to about 100,000 microsievert at one time to have changes in your blood cells. Okay. And this is where CBCTs are. We're between 19 to 70 microsievert. It really depends on which machine you use. Not the 70 is the end of the world. But you can see that, right? This is where we are. This is how low we are when it comes to exposure on radiation. So instead of repeating your X-ray about 5 times, 6 times, taking a panoramic X-ray to try and come to still an inconclusive diagnosis, a small FOV scan, that's field of volume scan, will just make your life much easier because it's not going to cause any trouble to your patient, and it will make your life much easier in terms of a practitioner, help in outcome for the patient. So it benefits everybody. So radiation exposure is the least of my worries when I talk about CBCTs. Okay. So those who are not very well versed with CBCTs, there's just a diagram to explain to you guys about how it works. All right. So you have 3 planes. You have an axial plane, coronal plane, and sagittal plane. When again, CBCT is 3-dimensional, so you can section your tooth in 3 different dimensions, all right, to get an accurate result in what you're looking for. So in an axial plane, you're going to be cutting the tooth or slicing the tooth from the coronal third to the apical third. So it goes from top to bottom. Okay. This is how it would look on your CBCT. So if you can see the first circle there, or oval shape with another oval shape inside that, that is probably your premolar. You will see the tooth top to bottom. All right. So in the middle is the canal space. The one behind that with the 3 different roots, that is your upper 6. You can see the root morphology on the MB. The mesobuccal, you have the mesobuccal as patent. MB2 seems a bit calcified. You have your palatal and you have your distal buccal. So that is the view that you're going to see it in the axial plane. Okay. In your coronal plane, you're going to be, yeah. So in the coronal plane, you're going to be slicing the tooth from the mesial to the distal. So in that direction. Okay. So this is an image of your lower mesial. So sorry, lower 6 probably. An endo has been done, and you can see the mesial root. So in that direction is where you're going to be viewing your CBCT. So you can go from mesial to distal. That's the mesial root. If I slice it a bit further, you're going to be able to see your distal root. All right. And your sagittal plane is buccal to lingual. So from the outside all the way to the inside. And that's how it will look. So these are your 3 different planes that we look at on a scan, regardless of whatever specialty you're in. This is going to give you enormous amount of information about coming up with your diagnosis or relevant findings that may impact your outcomes or treatment plan. Okay. So apart from the planes, you can slice your CBCT. So when I talk about slicing it, that means how fine do you want your sections to be? Okay. So you can, depending on the machine, you can slice the sections from 75 microsievert, or sorry, not microsievert, it's supposed to be micrometer. That's the wrong logo that I put on there. 75 micrometer all the way, so micron, to 25 millimeters. So you can see a tooth as fine as 75 micrometers, okay, to come up with, again, to find relevant findings. So it can be either this thick. Of course, this is not well adapted to how fine it may be, because that's definitely not 75 micron, but just to give you kind of an indication of how it works. Okay, so you can slice a tooth in this plane from 75 micron all the way to 25 millimeters. In endo, we like to use the thinnest slice, because we're looking at canals, we're looking at different anatomy, lateral canals if present, missed anatomy as well. So we need to look at the thinnest slice for endo. Okay. the same way, in the same plane, in a different plane, coronal plane, you're going to be viewing sagittal plane, you're going to be viewing it in these different thicknesses. Okay. So just to give you an example as to how it works. So if you look at it over here, okay, so this is your coronal plane. You have a 2.3 millimeter thickness. You can see the mesial root over here. And if I increase it to 5 millimeters, you can see the mesial and distal. Okay, so that's an endodont over there. So you can increase your thickness and then you see more of the tooth as well. Okay, but again, for endo, the thinnest is always the best. So case one, we're going to dive right into the cases. We have about 12 or 13 cases to go through. We'll be talking through all of them. We'll answer all your questions towards the end of it. So case one, talks like a duck, walks like a duck, but I need to see the duck. Now, what does that mean? So this was the patient referred. It was an upper left 6, well-condensed root fillings. As you can appreciate on the radiograph, treatment was done over 2 years ago. It was tender and percussion, palpation as well. Normal probing depth. So every assessment that you do, you should evaluate probing depth to see if it's perio, endo, vertical root fracture, perforation. It's a non-negotiable. If you don't do it, you should be doing it. Okay. We can see good crown margins as well. So that's a factor as well. See if there's any a plaque retention or anything like that. That might cause a perio problem. So, and there's no signs of perioral pathology. So why has this treatment failed? So that's what we're going to be diving into. So we have an inconclusive diagnosis over here. We do know that these teeth are notorious for having an MB2. The CT study tells us that it's about 96% or 97% based on which country you look at or what population you look at. A CBCT study tells us that it's prevalent between 91 to 93%. Okay, so it could be one of those. Okay, so when we look at this and we look over here, you see there's a lesion present here. There's no lesion present over here. So again, you're thinking, right? Initially, before you refer for a scan, you're wondering why it's failed. It's talking like a duck, walking like a duck, but you cannot see the duck. And this is where you will see the duck. That's in the CBCT scan. And when you look at a different plane, as you can see, it's a cheeky MB2. That's the culprit because there's no other reason why it should have failed. And apart from that, just look at the thickness of that the sinus membrane as well. The patient has some amount of sinusitis too. And I'm pretty sure if we do the endo and the lesion heals, that sinus membrane will also resolve itself. There is a CBCT study on that as well, that there's about 90% resolution of your sinus after doing your endodontic treatment. Right, so again, this is the first one of the first studies that was done, which was on a large scale. Again, it was by Shannon at King's, which was the detection of peripheral ptosis. And we compared 2D versus 3D radiology, right? So what does this paper say? And this is relevant to the previous case that I just showed you. So they assessed about 273 different roots. And on 2D, they only found a lesion present on about 20% and absent in about 80% of them. But when the same ones were looked on 3D, they found that there was about 48% lesions present on those roots and absent in 52, of course. So there was more than 100% rise in the amount of lesions that we saw on a scan, a 3D scan or a CBCT compared to 2D radiology. So, I mean, there's no doubt that CBCTs are more accurate and we should be using them to know exactly what we're dealing with. Because even, for example, the size of a lesion will kind of tell you what the success may be. There's a study from NG et al. Between 2008 going on to 2011, the prognostic factors as well as success factors for routine endodontic treatment. And yes, the size of lesion also impacts the success. So if you don't see it on a 2D, you take a scan on a 3D radiograph, you can actually measure it, and it may give you an indication as to how successful you may be. You want to give it you want to do 2 visits, 3 visits, 1 visit, you want to give a dressing. You can really pick everything that you want to do based on that. Okay. Right. So case 2, surprises. So this was another case, upper left 6 again. As you can see here, there's no obvious variable pathology. There's mild widening around the palpebral canal. The endo is very suboptimal. All the root fillings are not done well enough. But when we look at the scan here, the mesial has a lesion, the distal has a lesion, all right? And when you look at the 2D again, you can't even see the distal root. You can barely see the distal root as well. And when we look at, okay, this is another thing to think of or to notice is that when you look at even a suboptimal root filling, as you can see on 2D radiology on the left, when you look at a root filling, regardless of it being suboptimal, well condensed, a suboptimal root filling because of the scatter will look well condensed. So look at that on your left, look at the mesial root on the right. It looks very well condensed, but there's a lesion there. But if you correlate, it's not been done right. On your 3D, it looks like it's been well filled, but it's actually not. So that's one thing to remember, okay? So you cannot only rely on CBCT. To look at a quality of your root filling, you must be looking at 2D as well. And again, as we just spoke of, there's an MB2 here, but is that the reason for failure? It's not the only reason for failure. It's just not a well condensed root filling. It's not been done well enough. Okay, so all this while we've been focusing on that upper left 6, but what about the 7 over here? See that there's a massive lesion there. Patient is asymptomatic and you can't even see that on 2D. So what if you do the endo on the 6, you have success there, but the patient comes back in a week or 2 weeks or a month saying that, oh, I can still feel pain here. It was your job to assess the adjacent teeth to see if they're symptomatic or asymptomatic. You can do a percussion test, palpation test, and still the tooth can be asymptomatic. But if you're going to be taking a scan, you can at least assess the neighboring teeth well enough. So you can at least warn the patient or let them know so they're not surprised that there is another treatment to be done. They can choose whether they want to do it, because a lot of patients that are asymptomatic don't want to carry on treatment or don't want to take on a new treatment. But they should still be well informed. Okay, so that really tells you a massive difference between 2D and 3D, and that's of course a mic drop moment, because you would have had no indication unless there were symptoms that tooth was involved as well. Okay, so case 3, ask no questions here no lies. Again, everything we talk about on over here is all about diagnosis. It talks about even your patient history is very, very, very important. So this patient was referred to us. I think this was done at King's, one of my review patients, maybe, I'm not too sure, but it's still about 4 or 5 years back. So this upper left 6 came over. The patient was complaining of some dull ache, especially on biting and chewing. No history of swelling or anything like that, all right? And as you can see, the root fillings are well done. Yes, there's no crown on there. I can understand why it's not been given, because both marginal ridges seem to be in place. But there's no lesion as well. So why? Why is the treatment failed? Or why does the patient have symptoms? So when we look over here, there's a lesion, all right? So we're like, oh, okay. It's been done up to length. And so why is the treatment failed? Well condensed as well. So we asked the patient first question, was it done by a specialist? And they said, yeah, it was done by a specialist. And then we got it out of them. There was a retreatment done about 1 year ago, approximately. So this is where standardization of treatment comes into play, because in the UK, for example, if a treatment is done by a specialist, you expect the same standards across the entire United Kingdom, right? So if this was done by a specialist, I asked patients, can you get your records from your specialist? Can you ask them to email either the x-rays or send over the scan, and let's have a look, because why is the treatment failed? It's been done well enough and it's a well-reputed person. We need to understand why before just diving into treatment and being invasive for no reason, okay? So the patient got her records. She got a CBCT as well. That was taken by the treatment. And this was her pre-op. What we see on the left is the 1-year review, okay? I don't have the post-op because they sent us the pre-op. As you can see here, CBCT that was sent across as well. So there's a massive lesion here. Look at the image on the left. That's healed on your 2D. On your 3D, if you look at the lower left image, it's healing compared to the lower right side. And this brings us to another paper over here. Okay, so this basically becomes my 1-year review. And this gets us to this paper here. This is another paper again by Shannon, which tells us it's kind of a reversal of what we see. That, of course, if you don't see a lesion on 2D, you might see it on 3D. But if you don't see a lesion on 2D, you still might be having a healing lesion on 3D. Okay, so lesions appear to heal much slower on 2D, sorry, on 3D than on 2D, because of course you have more bone deposition that may appear on 2D than on 3D. because 3D is way more accurate. Okay, so this tells us the conclusion, which is that patient history is very significant, because we could have just spoken about okay, going into treatment. Also, yeah, sorry, I had to show you guys why the patient was having neck trouble. Sorry, I missed that indication. So if we look here, that yellow dot, that yellow spot over there, so the patient has some amount of probing with bleeding as well. So this tooth was basically perio in its sense, not extensive, but it just needed some debridement. You can see some widening of that space over there. She had food packing, there was a probing depth over there, immediate bleeding and probing as well, and a lot of dullness and pain and tenderness when we probed around that area. So again, no intervention required, just a good deep root surface debridement, and the patient would be well on the way and not come back for a while. Right. So conclusion: patient history is significant for diagnosis. Without diagnosis, as I said, we're glorified plumbers, and that would also tell us that we should spend enough time talking to a patient to get everything out of them. They don't tell you, but you need to bring it out of them. Okay, ask the right questions, take note of everything relevant that might impact on the diagnosis. Right, so case 4, misconceptions, radiology reporting errors, social media dentistry. This is quite a big case because there's a lot of misconceptions based on this one case. Okay, so this is the patient referred to me during my training at King's. This was, I think, in 2018 or 19, I can't remember. As you can see, I took 2 radiographs because you can't encapsulate that lesion well enough on one. And even after taking 2, you still can't see the superior border of that lesion, okay? And you have multiple teeth involvement going from 3 to 3, so about 6 teeth where a lesion is encapsulating. The patient complained of dull intermittent aches. He had a history of trauma, large hard swelling from upper right 3 to the upper left 3. 4 out of these 6 were tendon percussion, generalized tenderness and palpation, because if a lesion is extending from your 3 to 3 and it's a hard, large swelling over there, you're probably going to have tenderness all over there. Okay. So I did a poll on this on Instagram actually, and I'd asked a couple of questions about, what would be your treatment plan? How would you treat this? And how would you diagnose this as well? And this is the poll on Instagram that I had, right? So this was what I put up the question. The patient complains of a large hard swelling associated with the anterior 3 to 3 region, intermittent dull aches with a history of trauma. 4 of the 6 are mildly tendon percussion and generalized tenderness and palpation in the anterior region. And the question was, how would you classify or name this pathology? And those were the options. And as you can see here, most of, we have periapical granuloma, 16%. Most of the people which I thought would have given the answer to was, in fact, correct, which was cyst. They diagnosed cyst based on what we see there. And that's based on a misconception, periapical lesion and periapical abscess. And 71% of dentists, they chose histological terminology to diagnose a lesion, all right? So why is it relevant to CBCTs? Because no matter you take a 2D radiograph or you take a 3D scan, you cannot diagnose a cyst based on radiology. I know we've been taught in university, textbook might talk about corticated margins, etc., and that probably assists. But a cyst is a histological diagnosis, and that is not the right way to define what your pathology is. Because if you diagnose as a cyst, you're going to have a bias already in your treatment. Okay, so you cannot diagnose a cyst radiographically, you cannot diagnose an abscess radiographically, uh, or a granuloma for that matter. So what you would want to call this is a periapical lesion. I'm going to show you the case as well, as to why you can and why it should consolidate to resolve to use this terminology too. So this was the part 2 of the question. These were my clinical findings. 2 teeth don't respond to sensitivity testing. 4 out of the 6 teeth are positive TTP. Generalized tenderness and palpation for all 6, and a large hard swelling from upper right 3 to the upper left 3. And what is the treatment that you're going to be doing? And these were the results over here. And this is a summary of that. 73% of the dentists, and I had about 300 people vote on this. So we have a decent cohort, right? Different specialties, general dentists, specialists, all of it. So 73% of them, based on what they chose, they would treat at least 4 or more teeth, okay? And if you correlate to the previous one, or also the findings, is predominantly based on the fact that most of the teeth were tender in percussion or in palpation. Nobody took into regard that 2 teeth are responding well to sensibility testing. So that kind of tells you as well that, you know, we should follow our diagnostic principles well enough. Just because every tooth has a lesion doesn't need one. And why do I say this? Even though there's a lesion amongst all these teeth, I will show you exactly why. So again, going back to the periapical radiographs, these are indications basically on the response to endofrost. That's the core test that I use, because minus 50 degrees and it's the most accurate amongst all the other sprays that we have. So 2 of them are non-vital. 4 of them respond absolutely normally. The upper left 2, as you can see, is completely calcified. There's a history of trauma, it will make sense. And upper left 1 as well, previously accessed, and it does not respond to any cold. Okay, all the rest are positive. So what's my treatment plan is that I'm going to be probably working on what is not responding to cold. All right, so my plan was that I am going to, going on back to the diagnostic front, my bad. So we took a scan, of course. As you can see on the axial plane, this is the extent of the lesion. On the sagittal plane, that is how far it goes. That's how big your lesions are, okay? Associated with upper left 2, upper left 1. And the question is, why is it important to assess the spread of the lesion in this case? Because, for example, I do the endo and it's not responding to the endo. And in fact, it is a cyst. We're going to have to get oral surgery into play as well. So we're going to have to assess the extent of the lesion to see what are the anatomical landmarks in and around. Am I confident as well to go through the surgery if I need to do one? So I'm not, to be honest with you. If a lesion is that big, I would have gotten the oral surgeon to come in, do the excision, and I would do the exectomy required, right? So CBCT will tell you how far the lesion goes. Your 2 radiographs was not enough to tell you how far the lesion goes, okay? So going back to this, as I said, I decided to treat the ones that were not responding to cold. And I thought, okay, do you know what? I'll give the upper left 2 a go first, which is completely calcified, then go on to the upper left 1, right? So that was my treatment. The upper left 2, I tried to access it, went off track, and I just finished the treatment as it was. And the upper left 1 as well, I did the treatment apexification. I didn't have a condenser that goes all the way down to the bottom. Okay, and this was done about over 3 or 4 visits because there was a lot of suppuration through the canal. It was done over 4 months. But the plan was that we're going to review the patient back in 3 to 6 months, because in all likelihood, this is going to need surgical intervention because the size of the lesion is massive. That upper left too, given the history of trauma, calcification, size of lesion, just tells you that probably it's involved as well. So we said, okay, do you know what? We told the patient we're going to have to come back to surgery probably, but we'll still review you and send you off. Then the pandemic hit. We did not see the patient for a year. And when the patient came back for review, you see that the lesion is healing beautifully, all right? And if you look at that post-op, which is after 4 months, you already see bone formation over there, which is very easy to turn a blind eye to. And this one here, the upper left too, where I show you the yellow arrow, never really needed an endo. So it was only the one that was involved. And if that was a radicular cyst or whatever cyst, probably that would have not healed just with an endo. Okay. And if, as a layman, if you're not following evidence, looking at textbooks, if you look at that lesion, you're going to think it's a cyst. So this is a good case to show you that you should not diagnose cyst just based on corticated margins or how large a lesion may be. Okay, so this is the evidence to support it. This is a study done by Domenico Ricucci. He's a lovely histology person. All his section that he provides is done really, really well. He's the king of histology, actually, and it's done by Prof as well, Francesco Manocci, who I trained under. So what they did is that they looked at different teeth, I think about 60 different teeth with radiolucencies, and they classified them if they had corticated margins or not, right? And based on whatever reason, they did a surgical excision and they diagnosed them histologically, which is the most accurate way. And what they found is that teeth with corticated margins, only 3 out of the 10 were actually cysts, all right? Your radio opaque lamina dura, actually. And in the ones that did not have corticated margins, 7 out of the 47 were cysts. So that basically tells you that there's no correlation between a corticated margin and it being a cyst. So be it a CBCT, be it a routine 2D radiograph, it makes no difference and you should not be diagnosing it in that sense. Okay. So again, talking about that, can the type of periapical lesion be diagnosed on the basis of radiography? And the answer is no, including a CBCT. So if you're diagnosing a lesion, you should be calling it apical periodontitis or periapical lesion and not be using histological terminology. Okay. So when we look at, again, histological studies, only 15% of teeth were diagnosed as cysts. Okay, so about 85% are not cysts. If you look at a lot of lesions that may look like cysts, the prevalence is actually not that high. Okay, and the reason why we diagnose cysts based on corticated margins, again, comes from one paper, which is a case report from 1993 done by Nair and Jogren. And they could not, when they did the surgical excision, they'd never looked at the quality of the endo that was done. So they could not rule out that there was a failure just based on the fact that the endo was not done well enough, or if there was bacteria in the canal. Okay, so everything that we read in textbooks all about cysts and radiographs, corticated margins, comes from this study, which is a case report, which does not have a good hierarchy of evidence. And going back to that canal that I treated that was calcified, it actually never needed an endo, as we saw. And this is a good paper to show you as well, that only 25% of teeth that have calcifications, only 25% develop symptoms or have apical periodontitis. 75% of teeth with pulp canal obliterations are symptom-free and require no treatment other than radiographic monitoring. So again, that tells you, and that solves your misconception that every tooth that has a calcification should be treated. That's not the case. Only 25% of them need intervention. Okay. And going back to 2 teeth only needing an endo and looking at the size of the lesion with involvement of 6 teeth totally, stick to your diagnostic tests because that is very, very important. They're quite accurate. Your core test has an accuracy of 90%, 91% in terms of picking up if there's a disease, and 89.6% to tell you if there's no disease. So again, your tests are very, very accurate, not 100%, but it will at least make you treat lesser teeth or not cause an overtreatment of what's required. All right. Right. So this is taking you guys to radiology reports, which is what I see very often when someone refers a patient over to me about, they'll send over the scan on the slices, they'll send across a radiology report as well. And I look at them and I see that there's massive misconception, or rather, I think I would say it's a bit wrong the way they provide the reports to clinicians. Okay, so a colleague of mine sent these X-rays over to me, asking if I will retreat this and what would be my take on it, etc. Okay, and he sent over the scan as well, which was in a paper form. It was an upper left one. As you can see, overextended root filling, there's external inflammatory root resorption, and there's a lesion associated as well. And this is what the radiologist report had mentioned. All right. It says, based on radiographic findings, the lesion mostly resembles an infected radiculus cyst. Now, again, if a radiologist is going to send you this report as a clinician, you're going to already have a bias in terms of your treatment, which is not correct. That's probably just an endodontic lesion, just perigranuloma, which might heal with doing the endo just correctly, retreat it, and it might just heal. All right. But if you as a clinician receive a report like this, you're already thinking, oh, should I redo the endo? Should I call in an old surgeon, do an excision, apicectomy, and all that is overtreatment. And this is a radiographic report. All right. This is not only one of them. And as I said over here, what's important is that even the radiologist does not mention the overextension of the GP as well. Why is that important? Because if you can't get all that out, that is going to affect your treatment and your outcome as well. So it's very important that whenever you read radiology, you have to note down every little finding, because everything has an impact on outcome. Okay. This is another case, again, CBCT report. A colleague of this sent this to me, and the radiologist had mentioned that the pathology over here is suspected of a benign odontogenic cyst. Now, again, based on what? Just because there's a lesion that extends to 3 different teeth, can that not be a regular endodontic lesion? Okay. The nature of, the quality of root filling was not discussed either. And this again will give a bias, because my colleague called me up saying that, oh, the radiologist says it's a odontogenic cyst probably, with no differentials given as well. So should I just take the tooth out, get excised? And I was like, but why? You cannot diagnose a cyst based on radiology. If the endo is not done well, do it well enough, monitor the tooth, and see how it goes. Right? And this is another one here. This is another radiographic report that was sent. As I said, you should be viewing your scans on the smallest slice thickness. Here, the radiologist has sent over a report with slice thickness of 1 millimeter, which is quite high. You should be viewing them at about 75 to 150 microns to get an accurate diagnosis. So you see that there would be a bias based on the information given to you. You do not have the CBCT on your hand to view it. You give it to somebody else, they will give you a report and send it back to you, and you are dependent on that report. So you can miss a lot of information with these kind of slices and with these kind of reports as well. Okay. So as we see here, the radiographic impression noted by them is that it's periapical abscess. And again, you cannot diagnose an abscess based on just looking at a scan. An abscess is a histological term. It is not correct to use that. All right. And this is a part of social media as well. We see a lot of big dentists, this particularly one, a very, very big social media dentist, diagnosing cysts radiographically. And of course, a lot of young dentists follow this, which is absolutely wrong. This is Facebook as well. You cannot diagnose cyst radiographically. The image on the right on Facebook says CBCT investigation confirmed that it's a residual cyst. Based on what? You have no idea based on what. Okay, just because a lesion is big does not make it a cyst. Just because it has well-defined margins does not make it a cyst. Okay, so social media is not the best place to learn things from. I know a lot of people do that. They follow certain people and they think that they do God's work. But unfortunately, there's a limitation of knowledge there. On social media, we do post the best of what we want to post. The shortcomings are never kind of noted, all right? And this is one of them. Someone very confidently wants to talk about cysts based on radiology, and unfortunately, that is not the case. Okay. So the conclusion of this here, based on evidence, is going back to the same paper. Can you diagnose a cyst radiographically, including the CBCT? And the answer is no. Right? So cyst cannot be diagnosed radiographically. Every lesion doesn't need endodontic intervention. Endofrost is a reliable tool. That's a sensibility testing. And every calcified canal is not necrotic. So you don't have to treat every tooth that you see necrotic. You must monitor them because only 25% of them develop into an endo problem. All right. So case 5, as I said, without diagnosis, we just glorified plumbers. So this was the case that was sent to me by a dentist from a hospital. And this is exactly how the images were sent to me as well on a paper as a printout. Okay, so with a DPT that was taken, you can see there's a lesion encapsulating the 3 and the 4. The dentist sent it over because they said that they can't get down the canal in the 4, all right? And they'd already started treatment on these 2 teeth. And this patient was a very young patient, history of trauma, 17 years old approximately, and they had taken a CBCT as well. And this is again the image that was sent to me on the CBCT, as you can see, with pathology on the left. And this was the image sent to me on the scan. And again, the same view, all right? The dentist viewed it in the same fashion, sent me the slice and said, okay, I've initiated treatment. I can't get down the premolar. So can you please sort that out for me? And first mistake here is that they're viewing it on a slice thickness of 19.9 millimeters. So about 2 centimeter thickness is what they're viewing it on. Probably if they would have viewed it on thinner slices, they would have gotten a bit more accuracy as to what they were looking for. If they looked at the different planes, they'd have also seen what they were looking for as well. They never ran any clinical testing, no cold test, no percussion test, nothing. They just saw the lesion on this and they said, okay, we need to do an endo. All right. So I asked the patient to get me the scan, the CD, and let me view it myself. Regardless, the endo is initiated, but I should still have a look as to why, right? Like what's going on. And when I look at the scan, unfortunately, the pathology is not even associated with the canine nor with the premolar. So this tooth never needed to be intervened with endodontics or endodontic therapy. It just required surgical excision probably. So history of trauma, some form of cyst, maybe, we don't know unless we send for biopsy. But the dentist initiated treatment just looking at the DPT or OPG and not looking at the scan well enough. So unfortunately, these 2 teeth over here, both were accessed by the previous dentist. The reason why they could not get down is because it's a good hint, all right? When you look at premolars, they're very notorious to have these kind of bifurcations. As you can see over here, that the pulp space and the canal space disappears at this junction, and there is some sort of bulbous aspect to the root over here. So I can suspect complex anatomy. and you can see a deep bifurcation in the mid third. Did the endo, sent it back to the dentist, but honestly, there was no need for an endo over here. So again, this was over treatment. This was non-odontogenic. This is a good example to show you when a lesion is associated with the tooth or not. And had the dentist just run a cold test, they would have got absolute normal vitality or sensibility from these teeth and could have avoided this kind of treatment. Okay. So conclusions over here, DPTs are poor diagnostic tools for endo. That's also an OPG, as some may call it. CBCTs don't read themselves. You have to know how to read the volumes yourself. Again, sensitivity testing is non-negotiable, as seen over here and as seen in the previous case as well. So these are the conclusions from this particular case. Okay. Now, case 6, CBCTs and vertical root fractures. As I said earlier, you can't see a fracture that easily on a scan. So I've heard and seen a lot of people diagnose vertical root fractures just by looking at a scan because they think they could see one. Unfortunately, you cannot see one. Okay, that's a big misconception. Anyone who tells you that you can see this very blatantly, if you can't see it on a scan, you'll be able to see it with your naked eye or magnification. Okay, I'll show you some cases associated with this as well. So the misconception, as I just spoke of, you cannot diagnose it based on just looking at a scan. You have to do your clinical testing, probing depth, pattern of periradicular bone loss associated with it, and as well as the fact that when we talk about J-shaped lesions, all J-shaped lesions are not vertical root fractures. And again, I will show you about 10 cases why. Okay. So, what was it? Right. So this was one of the cases where was referred to us. And as you can see over here, there's no lesion associated. There's pre-op. We can see over here very much so that there is a lesion. Again, 2D versus 3D. So this needs endo. This was the endo done, and this is a 1-year review. Everything looks beautiful over here. No lesion, but the patient's still in pain and complains of intermittent aches, especially in biting and chewing. And okay, so why is the treatment failed over here? We look at the scan here. Yes, there is a J-shaped radiolucency there that is suggestive of fracture, but there was also a deep probing depth isolated. And as you can see here, there's a break in the periodontium here as well. That's indication of a crack or a fracture line forming too. All right, so again, compare 2D and 3D. 3D shows you so much more in terms of detection of lesions, but you cannot see a fracture over here. It's about how you correlate your findings, your clinical findings to your radiological findings. Okay, so, right, so if you look at all these pre and post stops on the top, okay, the common factor that we see all over here where the red arrows are, that they are in either forming a J-shaped lesion or have formed a J-shaped lesion. Okay, and but the thing is that are all of them vertical root fractures? If you look at all these below, the reviews, all these are healing or they've healed. Now, why does this formation of a J-shaped lesion happen, especially in mandibular teeth? It's because when you have periapical inflammation or healing, or a lesion, these lesions need to find the least path of resistance for draining. Okay, so if you let lesions be long-standing in your mandible, especially, they will start looking like J-shaped lesions on your 2D radiographs. You may have pocketing depths as well, only because they need a least path of resistance. Your cortical bone is very, very thick. Okay. So either it comes out in the form of sinus, buccal or lingual sinus, or they will start forming these kind of lesions, which may be indicative of a vertical root fracture, but they're actually not. you have to have visualization. You have to do your probing depths as well to come up to the right diagnosis. And this is about what, 6 cases that I can show you just at the top of my head, where you look at the images on the uppers with the red arrows, they are on their way or already formed the J-shaped lesion, but you look at the reviews corresponding at the bottom and they're all healed or healing. Okay, so this tells you cannot diagnose a vertical loop fracture just by it being a J-shaped lesion. So that's again a misconception. You have to do a lot of thorough clinical testing. All right, we look at this now over here. There's another case that was referred to me. And yes, we can see a suboptimal root filling, lower left 6, not well condensed. Patient is having pain. They remove the crown, cannot see anything. So why is the treatment failed? Yes, there is a lesion on the distal. Mesial, there's some widening as well. So I took a scan. I could find a probing depth over there. That was about 8 millimeters, isolated pocket. And this is what the CBCT shows me. So you see the red arrows? That's the kind of periradical bone loss that you may see associated with the vertical loop fracture, where it extends from your mid third to your coronal third, but on the apical third, there's no lesion associated with the mesial root. So that tooth is pretty much stuffed. It's got to go. Again, no fracture observable, obvious fracture line observable on a CBCT scan. Okay. So this is a good case to show you guys about clinical evaluation to come, to see vertical loop fractures. So if you look at this upper left one, this is the pre-op patient had independent ache. You can see a lesion associated with the 2 and the 1. Well condensed root fillings. Why the treatment failed? Took a scan. As you can see here, there's a break in the periodontium here. All right. The coronal third, this is the axial slice. This is the mid third. You can see that radiolucency. There's corresponding it to the center image. You can see that there is that break that I was talking about, all the way down to the apical third, corresponding with the lesion as well. Okay. So break in PDL plus bone loss is an indication, and have a look properly on your axial plane. That's the 3 images on the right, top to bottom, coronal, mid, and apical third. Can you see anything that looks like a fracture line? You cannot. The only indication that you have is the extent of the lesion, the way it's going down. And how common is it for you to see this kind of a bone loss or this kind of a pattern associated with an upper anterior? Not very common. So during my clinical testing, take a perio probe. There's an isolated 9 millimeter pocket. As you can see, there's bleeding as well. I use magnification. I use some retraction cords over here to get better visualization, some anesthesia as well to get hemostasis. And as you can see over here, there is a fracture here. Now going back to the CBCT, where you would ideally see the fracture line corresponding here, you cannot see a single tone of a fracture in terms of the crack line associated. Okay, so you can see clinically, but you can't see it in CBCT. So that tells you again that CBCTs are not the best tool to detect the vertical loop fracture. They give a good hint or an indication as to there may be being a vertical loop fracture, but you have to evaluate it well enough. And we have enough evidence to support that. Again, this is a paper done by us at King's. And as you can see, the conclusion as well, that under conditions of an ex vivo study, CBCTs were not accurate in detecting the presence or absence of a simulated vertical loop fracture. And when you have root canal treated teeth, as we saw in the second case about surprises, that they look well condensed even when they're not, and they also pose as artifacts and cause a lot of scatter. Okay, so you might your imaging artifacts caused by gut aperture, root filling within the root canal most probably resulted in overestimation of a vertical loop fracture with CBCT. Okay, so they're quite inaccurate. You can have scatter, which due to the way the scatter looks, it might look like a crack line or a fracture, but it actually is not. Okay. This is another study as well from the JOE done by us at King's as well, that your CBCT imaging had a low sensitivity, that's 27% and 15% respectively, that indicating that there is a fracture in a tooth. Okay, so your sensitivity, that is to pick up disease, is very, very low when it comes to vertical root fracture on a CBCT. So do not rely heavily on CBCTs to diagnose a fracture, because we just saw some limitations based on that. You cannot look at there, you cannot visualize them about 70% of the time. Okay. This is a good paper again. This was by this again by us at King's, by Shannon, Bhavin, and Rahul. It's a free download. There was an edition by the IEJ, I think in June, which was a review edition of different topics in endo, and they're all free downloads. So I would say that if you do fancy reading, go ahead, look for these papers. They talk about a review of literature of various different topics, and you can really enhance your knowledge with that. So talking about vertical root fractures as well, you can talk about clinical features and the radiographic features. Have a read. I'm not going to go through them because that's a whole different topic. We're talking about CBCTs associated with vertical root fractures. Okay, and these guys are the authors. The day this paper got released, that's Rahul and Bhavin. We went out for a couple of pints, and I clearly seem happier than the others about the acceptance of this paper. But yeah, we just had a couple of pints, so that would kind of answer as to why. Okay. So case 7, this was another case, internal referral. It was an upper right 4. It was initially treated by a specialist, premolar, and the patient, the symptoms still persisted. So they tried to re-intervene, and they said, okay, do you know what? We're just going to refer the patient. They sent it over to me, and they sent me the history, everything, and the patient had sharp pain and biting. Endo was done over 2 or 3 visits, but the symptoms were persistent. So first things first, did my clinical testing, examination, and looked at the radiograph. And I looked at this over here, and I was like, oh, why is there this radio opacity here? Is there a perforation? Is that why the patient is complaining? But even if it is, I still want to take a CBCT prior to intervening over here. Okay, so I took a scan, and this is what the scan showed me here. So there was basically, this is an upper 4 with 3 roots, and the previous dentist had missed this root, and that's exactly where the lesion is associated with. Now, even though when I look at the radiograph, I may think there's a perforation, and the fact that there's a missed canal over here, which is the 3rd root. So am I wrong that I thought it's a perforation? I'm not wrong, but I've just corrected myself, and I know exactly what to do over here. First things first, get inside again, remove the existing filling, look for that 3rd canal, obturate, and the patient should be absolutely fine. So the prevalence again, your upper molars and lower molars, they're quite notorious to have extra canals. They can have bifurcations, trifurcations. In this case, we have 3 roots. Very rare to have that in upper premolar, but it's not that we don't know of them. Okay, and there's no indication here that would tell me that there was a 3rd root in here. So this was my pre-op. That's my post-obturation. That's my post-op after as well. And now when we look over here, that's the extra root. But again, I can't see the root outline at all. I don't even know if I'm up to length or not. That radiolucency you see over here, that is where the lesion is. Again, without a CBCT, I would have never thought that that is an endodontic lesion, or there's a root associated over there that is causing a problem. Okay, so again, big limitation of 2D radiology. And the fact that I did not even know if I was up to length or not, I told the patient I'm going to take a post-op scan to see if I'm up to length, because if I'm overextended, I can expect maybe a failure. If I'm under-obturated, I can also expect a failure. Okay, so I took a post-op scan, and I viewed it in this plane here. That's my MB. That is my distal buccal, which was the mist canal, and that is my palatal. And all of them are up to length. So I can tell the patient, you know what, happy with that treatment. Let's review you back in about 6 months' time. So her review should be due in about 2 more months, and we'll know whether this treatment is successful or not. But again, CBCTs gave me a good indication, made my treatment very, very predictable. I knew exactly what I was looking for instead of wasting time and finding an extra canal as a surprise. Okay. Now, cases like this. So we have two frames of mind, like when I do treatment, especially when I do a lot of complex cases. One is it's a bloody tooth, care for it, keep it, do whatever you can to save it. And the other one, when they're really challenging, is it's just a bloody tooth. But you know what? Maybe take it out because it's a massive headache. So this was one of my cases. If any of you guys follow me on Instagram, you might have seen this. This is fairly recent. So again, going back to understanding reading a radiograph is very, very important. Okay, because without the information on a radiograph, you will not find what you want to find on a CBCT, right? So this is a very good very good example as to what all information you can derive from one radiograph to get the best out of CBCT as well. So this was referred to me again. It was a lower left 6, young patient, looking at all the challenges. I was like, you know what, I want to save this tooth, try my very, very best. Endo was done about 15 years ago. So when we look at the radiograph, there's an amalgam restoration here. There is some sort of a fracture of the mesial cusp or mesial aspect over here. Amalgams are known for the hygroscopic expansion, and therefore also notorious for finding cracks underneath them upon removal. Okay, so there's a fracture associated over here. There is an in or unaccessed pulp chamber. So they just probably did a truss cavity, maybe way before truss was actually a novel technique that was being used. So it was not being accessed properly, suboptimal root fillings, obvious periapical pathology with your mesial and distal roots. There's a lateral lesion associated as well, and calcification present. As you can see, you can't see the canal outline very well. When I look at that, it's a bulbous root. I'm expecting one canal here and maybe one canal over here. So first things first, I take a CBCT. That's my mesial, that's my distal, and as I said, the canals are completely calcified. Now, when I look at that distal there, there is something that I am dreading, which is one canal outline here, second radio opacity, a second canal going here, and there is a third one in a different direction here. So there is some sort of a trifurcation in this distal canal, and they're calcified. So again, if I did not take a scan, I would not know what to look for. I would not modify my access cavities or my canal spaces to try and hunt for these kind of trifurcations or bifurcations. Now that I know it, it's not predictable because they're calcified. It's going to be difficult, but at least I know where to look, all right, where to identify. Now, when I look over here as well, this confirms it. This is distal 1. This is distal 2. And there is a completely missed distal 3, all the calcified at some level. So I know what files I'm going to use. I know how I'm going to go about this. Patient has been made well aware of the treatment challenges associated here as well. So they know what to expect, that what if this treatment is not successful and what are the hurdles that could pose for me completing the treatment. Okay. So as you can see on the images on the upper left, I used about 40 C pilot files to negotiate these canals. I separated one of them as well. I retrieved them while trying to bypass it. That was absolute luck. I did not intend to retrieve it, but it came out, thank God. And I finished the treatment. It took me about 3 long visits. But yeah, like if I did not have a CBCT here, yeah, we may talk about, okay, this looks lovely, etc. But had I not had a CBCT here, I'd have not got half of the outcome that we see over here. So it's all about your pre-endodontic evaluation, optimizing your CBCT well enough, but also looking at a radiograph well too, to refer the patient to get a scan done. Because if you can't read a 2D image well enough, you will not be able to optimize or refer the patient for a scan, because you're missing out so much information. So you won't know when to refer or not. Okay. So this is, I took a post-op scan again. I consented the patient because I wanted to take a post-op scan to understand anatomy and for educational purposes as well. Because we're running a CBCT course, Burzine and I, in Feb. We'll talk about that a little bit later. But I took a scan for education purposes, and as you can see, your D2 has a lateral exit. If you look at the second image on your left, on the lower left side, you can see two distal canals going all the way down to the bottom, but where does the middle one go? If you look at that middle image there, the D2 exit is lateral. That's the puff that you see, or ciliary extrusion, or whatever you want to call it. That's where the exit is. So that was an accessory canal, which was viewed on a CBCT. So again, you get so much information to make your treatment a bit more predictable and make your life a bit make your life a bit easier, right? So case 9, seeing is believing. This periapital radiograph, upper left 4. As you can see, there's resorption. Ideally, we've been told in textbooks that we should take parallax radiograph to assess extent of resorption or some amount of spread of it. This is a parallax view that I see over here. And is this internal or external? I don't know. Does this reveal much? Again, I don't know. I don't have enough information here. What's the spread, pulpal involvement? Yes or no? Circumference that's captured by the resorption? I have no idea. Okay. And again, that's a limitation of 2D radiology. We have been taught about the Hidesai classification that I spoke of very briefly earlier, which is a 2D classification from the early 80s about external cervical root resorption. But is that accurate? Unfortunately, it's not. So when we look at this, same thing on a scan, right? These are 3 different planes that we're going to be looking at it in. Look at that spread of the resorption. And you have no indication of that in terms of when you look at that on a 2D radiograph. Okay. You would not know how, if this is restorable or not. When you look at 2D, you're like, oh, okay, do you know what? Maybe this is restorable. But if you have to raise the flap to check that out, you're gonna have done over treatment in some way, because you would have been walking the surprise and wasted your time as well as the patient's time. So as we say, this is as good as dog's dinner. This one's got to go. It's done its service. Okay. So this is the new classification. Again, this is available as a free download on PubMed. This is your 3-dimensional classification of external cervical root resorption. Again, by Shannon, by Federico, Prof, and Krina. So this basically is a classification that is based on looking at a CBCT. It tells you the height, your circumferential spread, as well as the proximity to the root canal. So it will tell you the location of it, how much it spreads as well, and does it involve your pulp or not. And everything has a prognosis, as well as it affecting your survival and whether this tooth should be kept in function or not. So I'm not going to go through resorption. You should check it out, look for this article, or take a picture of this. And this is what is an accepted classification for external cervical root resorption. But case 10, again over here, I suspect resorption. As you can see, this is not your normal canal morphology. I take a CBCT and I have a look at that. That's rather a wide canal, but your apical foramen is rather narrow, suboptimal root filling, and there is no communication with the external, with your external landmarks associated with resorption. So this is very much internal root resorption. Don't have to do any exploratory surgery or check my working length, my apex locators from getting funny readings at different times. Spares me a lot of trouble and a lot of surprise, internal root resorption, and this is my treatment. Just an MTA apical plug, 5 millimeters, 5 Boston core. So again, so we saw two cases. One was external cervical, and one is internal resorption. So you can actually tell the involvement, how far resorption goes, and it just spares you a lot of trouble in terms of treatment, and you don't have any surprises in that sense. Now, case 11, outside the box thinking. So this is some things that are not in the guidelines, but sometimes you have to think outside the box. And I'm lucky that I have a CBCT at my disposal. It might not be possible for everybody, but this is some ways that I use a CBCT for basically making my life much easier in very complex and challenging cases. All right. So this was the case referred to me. It's an upper right 6. Previously accessed. Dentist could not find your MB2. And as you can see, it's very, very calcified. If you look at the morphology of the root on the top right 2 images, there you can see how bulbous that root is. There definitely is an MB2 somewhere over there. If you look at the image below that, where it says calcified canal, that's your axial view. You can see the MB in that root, so MB1, but the MB2 where the arrow goes, it's calcified. And again, if you did not have an MB2, your canal would be central in that root. It would not be on the side. Okay. So I said, okay, let's give it a go. Let's initiate treatment. So I started drilling and troughing inside into that space, and I could not find it. So I placed calcium hydroxide over here to use it as a dye. Okay. And I gave a temporary restoration, and I took an intra-op scan. And when I scroll down through the scan, I see that this is where my calcium hydroxide dressing is. And just next to that is my canal space over there, somewhere there. And I'm missing it by about 1 millimeter. Now, if I keep troughing where I am currently going, I will cause a strip perforation. I will not find the canal. So thank God I took an intra-op scan. I re-contoured where my ultrasonic should be, re-gauged it, changed my access, and went hunting for that canal, and I found that canal. So as you can see over here, that's my MB1, MB2, well filled, my distal buccal well filled, and my palatal very well filled. Some sort of lateral anatomy that got filled in the palatal, as you can see. You might think, oh my God, your irrigation protocol must be good. No, this is by fluke. I did not intend to do that. Every time you get lateral puffs or these lateral anatomy filled, it's not because clinicians intend to do it. They don't look for it. They find it by chance. So I would not say that, oh, this was done beautifully. That was absolute luck. Okay. And if you can see here, it's a repeat video. Sorry, that MB2 is very, it's not in its usual location. It's in a diamond shape actually. So using a CBCT here was very, very helpful. Okay. This is another one, and this is a patient who came to me. He had a massive gag reflex. Wanted to get the upper 7 retreated, and with the rubber dam and using RVGs, the RVGs are very bulky. Getting X-rays were very, very difficult. So I could not get a decent intra-op, a pre-op radiograph. So I said, okay, do you know what? Let's just take a scan. Let's try something new this time, because normally I always take a pre-op radiograph first and then take a scan. But I said, okay, today, do you know what? Let's just try something different so that we can cause minimal discomfort for the patient. So took the scan. As you can see, there is suboptimal root fillings. There's a lot of extensive bone loss on that mesial aspect of the 7, but there was no fracture observed. And the plan was simple. We're going to do a retreatment over here. But again, could I take intra-op PAs? It would have been very difficult because rubber dam, RVG, patient has gag reflex, not possible. Rubber dam is non-negotiable. If I could not put that on, I would have taken this tooth out. That is something that I will always say, that if I can't put a dam on a tooth, either find a way or extract it. So that was a non-negotiable. So I said, okay, do you know what? Let's try something outside the box. I'm not very confident about it, but let's give it a go. Okay. So that's your MB, that's your distal buccal, that's your palatal. I decided to measure them on a CBCT, the working lens. All right. So I have 15 point something on my mesobuccal, 15 millimeters on my distal buccal. My palatal is 16.8 millimeters. And what I did was I corresponded these working lens to my apex locator working lens. Again, you had taken all the GP, apical gauging, everything, all protocols in place. And I corresponded these lens. They were not exactly the same, but they were close enough for me to be confident to go for observation. Okay. So these are my pre-ops. That's my post-op. My MB, if you compare the image above, with a curve, well filled all the way down to the bottom. Distal buccal as well, well filled to the bottom. That's my palatal. I got an extra 1.5 mil apically and got it done well enough to my apex that I would require. Okay, so yes, I was not very confident. I would always take periapical radiographs in my intra-op sequence of treatment, but unfortunately here I could not, so I had to try something outside the box. Okay, so case 12, this is one of my last few cases. Is there a perforation here? As you can see, we took a scan. When you see that over there, the dentist was looking for a canal, looked calcified, could not find the canal, almost perforated. But we took a scan and we saw that the dentist had not perforated here. Okay, so if you see, that's where the wrong axis ends. There's no break in the cementum over there. There's no lesion associated. So that does affect my prognosis. If there was a perforation, my prognosis would have been lowered as well. And if you see that yellow line on the right side, that's approximately where that canal would be. So again, we know where we're looking at the canal to be. We know where the perforation, where the almost perforation, the misaccess is, and we can plan our treatment well enough. Okay, so no perforation, canal is present. And this is the treatment that was done. This was treated with biodentine. That's misaccess there because it has good compressive strength, close to dentine. And we treated like a perforation, not that there was one. Okay. So again, this just helps in planning your treatment very well. Your CBCTs aid in so much information that you can sit with that for a day prior to diving into treatment without knowing what you're expecting. Right, so when we look at this over here, retreatment, should we do one here? There's a lesion on the distal canal, suboptimal root filling, sinus tracking as well, some widening on the mesial root as well, but well obturated is the canal. But when we look at that scan here, I don't think we're going to be retreating that. That's probably a fracture there. So again, you see how much information you get from a scan. There's absolutely no lesion or maybe mild widening on a CB or on your 2D radiograph. But look at that scan. That has got incredible amount of bone loss there. Okay. So when we look over here, second last case here, what's going on here? And here as well. So this is understanding how to read radiographs really well so that you can refer them for a CBCT. So now when I look at that upper left image, there's a post in there. Okay, well condensed root filling. But why did I refer it for a scan? Because if you see where that post ends, okay, the lesion begins there. So I'm thinking that's a bit funny, that's a bit odd, as well as the fact that where the post space is, the material or the radiolucency or opacity over there is very coherent with my root filling as well. And that's not how a cement would normally look. So that was a bit dodgy. So we took a scan. And that's what we see here. That's perforation there. And as suspected, when we look at the image on the upper left, where the post ends, the lesion begins. That's because that's perforation. The image on the right side, see where the post direction is. It's a little bit off-centered. That's where the canal space normally would be, and that's where your host is going. So that's an indication again to refer for a scan. There was no probing depths, but if you don't suspect it, if you don't know enough, you will never be able to refer for a scan. Okay, so this is a very good indication as to why CBCTs, because you would have never had this indication had you just relied on 2D radiology. Okay, and this is the last one. This is a bit of dental trauma. Patient came over, referred by their specialist, feeling some pain, and trauma was about 3-4 months ago. Teeth was splinted. Now I looked at that over there. There's some lateral widening. Wonder why. There's no apical lesion that I can see as well. What's going on? So we take a scan, and here it is. There is a horizontal / oblique root fracture, and there's no indication that you can see over here. Yeah, you can see a mottled appearance, but that's a bias because you can already see that on a CBCT. That's why you see a bit more on the 2D as well. Okay, so again, this is why CBCTs, they have their place in endo, and very strongly so. They should be supplemented with your 2D radiology to make your life much easier, better outcome, better treatment planning, and better diagnosis. Okay, so this is these are a couple of papers about when cases were assessed with and without CBCTs and how the diagnosis and treatment plans changed. Okay, so here 81 cases were assessed. 42% of them, their diagnosis had changed. When 30 cases were assessed in this paper, 45% change in diagnosis, 62% change in treatment. Here again, 30 cases, 27% change in treatment. Again, 30 cases, 55% change in diagnosis, and 49% change in treatment. So that again tells you as a clinician, when you view more and you make and you see much more, you're gonna probably be changing your initial diagnosis, which is based on 2D, which does not give you enough information. All right, and this is another good paper about assessing the confidence of specialists as well as trainees with and without CBCTs, and the conclusion was very obvious that all these clinicians, they felt much more confident in terms of treatment plans, especially in complex endodontic cases when they looked at CBCTs as opposed to not. All right. So that brings me to the end of this webinar. Thank you guys for signing in. So that's my conclusion, and that's a periapical, that's a parallax, that is your CBCT. You get a holistic approach. You see much more. It's a 3D, three-dimensional view of a three-dimensional object, and the evidence all suggests so, as well as all the cases I've shown you, that CBCTs are something that should be used routinely in endodontics. Right, so this just gives me an opportunity to talk about a course that Burzine and I are doing. It's in association with the Digital Dental Forum. We're doing a CBCT workshop for implants as well as endo. It's a 3-day workshop that we are hosting. It's going to be between the 17th to the 19th of Feb in Mumbai. It's at the IDA head office. How it's going to work is that the first day is going to be common for all participants. You're going to be learning about 2D radiology, as we spoke of, as well as the limitations of them, and learning about the CBCT software, which will be installed on your laptops. Day 2, if you sign up for endo, you're going to be training with me. And you're going to be given case volumes of various case complexities to read and report your relevant findings. It's going to be very much hands-on. And on your day 3, it's going to be with Burzine. You're going to be learning about CBCTs in implantology. You're going to be using the CBCT software for implant planning, that's the core diagnostics, and also learning about how to make a static guide design. So it's a very new program. It's the first one in India that's going to be of this kind, and as well as that, it's been adapted from your British. It's been adapted from a course at the British Dental Association too. So please send us an email, if you guys are members, at the DDF email ID, and get in touch with us if you guys fancy joining the program. Right? Thank you. That's me on Instagram, shaurya.endo, and that's my course page. And yeah, that's me. Thank you so much, Burzine, for having me. I hope that was fine.
Yes, absolutely, Shaurya. Thank you very much for joining us on our EdTech webinar series and for a very informative lecture with a complete overview on different endodontic lesions and how CBCTs help us in each one of them. Um, we're looking at some questions that have come up, and the first one is from Zishan. Any thoughts on guided endodontics?
I mean, yes, guided endo has its place. There's a paper by Moreno from it in the IEJ 2019-2020 as well. It's a very novel approach. We use it for cases where there is calcifications. The predictability of finding a canal ranges from about 91 to 93%, depending on what tooth you're looking at. The limitation of guided endo is that you need to have 3D printing, you need an intraoral scanner, you need to superimpose the CBCTs with your DICOM files your STL files. To make a right guide design, you need the right burrs for it as well. So yes, guided endo is definitely a great option, but you can't be using them in all cases. I think the cost for every treatment is very high. But yeah, for calcified canals especially, they are known to be very, very predictable, about a 91% accuracy in finding canals. So to know more about it, check out the paper from Moreno, Moreno. There's a review of literature on that. I think it's 2019. He has a two-paper sequence in the IEJ. So have a look at that. And if you have any more questions, please feel free to ask about guided endo.
Shaurya, you spoke about misleading reports from either reporting centers or from referring dentists. What is it that the dentist who is referring out for a CBCT should be asking for in those cases?
So I think, I mean, not I think, honestly, when we refer a patient for a scan, I think the radiologist also should be made aware as to why they're being referred. You cannot just say, okay, I want a better view of this particular area. You need to give your clinical findings as well, because a radiologist will just look at the black and white or the gray and white and come up with their findings. But as if you want to get an optimal report from them, you need to send your clinical findings as well. So, for example, if you're looking at a lesion that's an extensive lesion, there is a pocket associated over there. Um, is there intrabony defects, for example? Is the perio stable, for example? So that will differentiate whether it's a fracture, if there's is just the least path of resistance, is it an endoperio lesion? Like what is it? They as radiologists, they don't know. You have to send them your findings, clinical examination, patient history as well, for them to actually develop an endodontic diagnosis for you or take away the endodontic component, because you can have a tooth with a lesion, okay, encapsulating the root as well, but you have an absolute vital tooth. Now what is that? That can be many different things, right? You have non-odontogenic lesions as well that may appear as endodontic. So you need to write a thorough report to the radiologist, as you would as a prosthodontist, for example, to a lab, about what you need and how you are viewing things, so to get a better diagnosis from them.
Yeah, that's right, absolutely. But any particular pointers that you would indicate for such a kind of referral?
I mean, so what I would do is I would number one note the patient complaint, the symptoms, all right, because symptoms give you a lot of information required, all right. Your clinical findings, as well as assessment of your adjacent teeth, your percussion testing, palpation testing, core testing, pocketing depths as well, and periostability. Get all of that in place. Then you look at your periapical radiograph, correlate that to your periapical, and then you see that, okay, I can see this, but I want more information because this is a bit inconclusive. The story is not complete. So you need to note down everything that you see and why do you think it's not complete, for them to give you a better report. Because they can give you a very general report and it's not going to answer your questions, and that's going to give you a bias for over treatment or under treatment.
Yeah, also, I guess with most of these centers, it's not an clinician who's giving the report, and it's more likely a technician who's doing it. So,
Exactly.
yeah. You also mentioned as to radiology not being conclusive with cystic diagnosis.
Yeah.
So, are there any other things that you would look for, or how do you diagnose a cystic lesion?
You can't diagnose cystic. The only way is excise it, send it for a biopsy, and get a zoological report. We
So,
have
would your
enough
treatment
evidence
plan
from
differ in that case?
89. Sorry.
Would your treatment plan differ if you diagnose a cystic lesion, and how would you treat it?
No, I mean, so for me to, I can't conclude that based on radiology. So if it's suboptimal root filling or a root filling done without a rubber dam, not up to standards, and there's a corticated margin, I will still do the endo, monitor the tooth for about 6 months to a year. If the lesion is becoming bigger or it is pretty much the same, not resolving, then go for your apical surgery with a retrograde fill as well. Send it for a biopsy. In all honesty, it can still be a granuloma causing a failure of endo treatment, but there's just a very high bacterial load. So we will never know unless and until we send for histology. There's no way of finding it.
Okay, as far as what is your opinion on intra-op scan or a post-op scan?
Intra-op scan I take, as I said, in very few cases where I think I'm going off track, calcified canals, etc. I don't take them always. Indications for them are few. So I would say in maybe about 3% of cases I would take an intra-op scan, calcified canals or removing of some filling that your root filling that has completely discolored and you have no indication as to where you're going. Because I've had that one case before. It's not a root canal filling, but like something like a magic mix which totally discolors your pulse chamber and your canal space. So I've taken an intra-op scan for that as well, but I don't think I've taken an intra-op scan more than 7, 8 times. In all honesty, the indications for that are very, very low, and it's also a matter of having that machine at your disposal, whether you take that option or not. So that's a matter of convenience, which is unfortunately not available for everybody. And
True.
post-op scans, um, there's no place. I mean, there's no need for post-op scans. I take them because I consent the patient for education purposes. Because I talk a lot on CBCTs to understand anatomy, etc., correlating my pre-op to my post-ops. So I take them only when I think that there's an indication to that some students or clinicians might learn from that. So there's no reason to take a post-op scan.
Okay, and the last question now is to do with prognosis of perforations and bioceramics.
Oh, that is a completely different topic. That is a completely different topic. I don't think there's I mean that I can talk for about 2 hours.
Can you
And
conclude in
anybody
one
who's asked that question, honestly, send me a message on Instagram. Okay, I'm talking about this on the 20th of December. On this Endo series platform, it's going to be about a 3-hour talk about bioceramics as well as perforation repairs. So that is going to be a very, very I mean, it's going to be a very in detail conversation because perforations by themselves, there's a history to talk about from 97 until now and where we are in terms of material being used as well. So I don't think that's a question I can take on and give you an answer because that's a very vast topic, unfortunately.
Okay, fair enough. So we look forward to 25th December. Is it also an online program?
And 20th Jan, it's online. It's online.
20th Jan. Okay.
So just send me a shout on Instagram and I can send you guys the details to register for that.
Okay, that brings us to an end, and thank you very much, audience and Shaurya, for a patient listening. Thank you very much, and it was a pleasure to have you on board, and we look forward to your future collaboration. Thank you.
Cheers. Thank you.